Bismillahirrahmanirrahim. Today we will discuss abnormal intracellular accumulations. And in today's lecture, we will discuss mainly the abnormal accumulation of fat within the cells. Normally, the cell has a limited ability to synthesize, store, and transport various substances. The abnormal accumulation of various substances in the cell may be either synthesized by the same cell where abnormal accumulation occurs, or it may be transported to the cell when it is synthesized somewhere else and is transported to the cell in greater amounts where it gets accumulated. The abnormal substance may be accumulated in the cytoplasm. It may be accumulated in the organelles, mainly the lysosomes, and sometimes the abnormal accumulation may occur within the nucleus. Mild forms of abnormal accumulations are mostly harmless. But if the accumulation of a particular substance exceeds some defined limits, it will become injurious to the cell. The various pathways where abnormal intracellular accumulations occur, for example, if there is inadequate removal, for example, if excess fatty acids are transported to the liver, that may occur in diabetes, alcohol, non-alcoholic fatty liver disease, various toxins like carbon tetrachloride. So these causes will lead to abnormal accumulation, excess accumulation of fat within the liver hepatocytes. Sometimes in a cell, there may be genetic or acquired defect, and the outcome of this defect is there is defective folding, packaging, transport, or secretion of various substances. For example, in alpha antitrypsin deficiency, which is an enzyme that protects particularly the lungs from the neutrophil elastase enzyme. So here what happens that the problem may occur in the liver, or it may occur in the lung, and the lung is damaged by the neutrophil elastase, and the outcome may be in the form of emphysema. Sometimes some inherited defect in an enzyme which may result in failure to degrade a metabolite, and the result of this inherited defect in an enzyme or more enzymes may result in the abnormal accumulation of that particular metabolite in the cell. The example are the lysosomal storage diseases, which occurs due to inborn errors of metabolism, and a simple example is the Tay-Sachs disease. Sometimes the cell may lack the enzymatic machinery to degrade a particular substance, and due to lack of this enzymatic machinery, that particular substance cannot be degraded or metabolized. And the examples are the exogenous substance, for example, the accumulation of carbon and silica particles that lead to abnormal deposition of carbon in the form of anthracosis or silicosis. So in this situation, the cell doesn't have the enzymatic machinery to degrade, to break down, or to transport carbon or the silica. So the common abnormal substances that get accumulated in the cells in the form of abnormal intracellular accumulations include deposition of lipids, and today we will particularly discuss the fatty change, which is abnormal deposition of high amounts of fats in the form of triglycerides that get accumulated in the cells. Next, we will discuss abnormal cholesterol deposition in the form of cholesterol in the VLDL particles, and it may lead to uh, some serious diseases, for example, the atherosclerosis, which is mainly responsible for myocardial infarction, cerebrovascular strokes, and peripheral vascular diseases. We will also discuss the abnormal deposition of proteins in the cells. We will discuss the deposition of glycogen, which is formed from the deposition of glucose in the form of glycogen, mainly in the liver and skeletal muscles. We will also discuss the abnormal deposition of some pigments like hemosiderin and lipofuscin. And finally, we will discuss abnormal deposition of calcium. So abnormal deposition of calcium, which is known as the pathologic calcification, as compared to the physiologic calcification that occur physiologically. So the pathological calcification may occur in the form of dystrophic calcification, which usually occurs in the damaged areas in the body by certain diseases, or in some conditions in which there is systemic hypercalcemia, the calcium may get deposited even in normal tissues, and this is known as the metastatic calcification. Now, as we know that we define fatty change as an abnormal deposition of fats in these cells, and this particularly occurs in those organs where lipid metabolism occurs. The major organ is the liver. So in the liver, alcohol may cause abnormal deposition of fats, and in other conditions known as the non-alcoholic fatty liver disease, some other causes other than alcohol, for example, diabetes, obesity, metabolic syndrome, and some toxins like carbon tetrachloride may cause abnormal fat deposition. Protein deficiency, starvation, and anoxia or hypoxia, which leads to decreased fatty acid oxidation, may also cause abnormal deposition of fat in the liver and sometimes in the skeletal muscle and other organs. Now, before we go to discuss abnormal fat deposition, we recall the normal metabolic processes and the normal fat metabolism that occurs mainly in the liver, and if there is some defect in this normal metabolism, there it will lead to abnormal deposition of fat, because either the entry of the fat is increased or there is decreased removal of the fat from the cells. Mainly it occurs in the liver, but may also occur in the heart, skeletal muscle, and kidneys. Normally, fatty acids in the liver are either synthesized here, and in the case of increased lipolysis or breakdown of triglycerides into fatty acids, there will be excess entry of fatty acids into the liver. We know that the acetate or the pathway of acetyl coenzyme A, in which carbohydrates are converted into fatty acids. So fatty acids may be derived either by increased synthesis in the liver from acetate, or entry from the blood, and normally these fatty acids are either oxidized to ketone bodies for energy. These fatty acids are used to form phospholipids, which are very important components of the uh, cell membranes, and also needed for the formation of the uh, various components in the body. And the same fatty acids may form cholesterol esters to esterify cholesterol. So the remaining fatty acids, in addition to these processes, it will react with alpha glycerophosphate, which is derived from the glucose metabolism, and these fatty acids in combination with alpha glycerophosphate form the triglycerides. Now the triglycerides accumulate in the liver, but there is uh, a pathway in which these triglycerides combine with the apoproteins to form the lipoproteins, mainly the very low density lipoproteins, and that is a way of carrying out these fats and triglycerides outside the liver. Now, any defect anywhere in these physiological processes may result in abnormal triglycerides and fat depositions in the cell. First, we discuss the alcohol-induced fatty liver disease, that is known as the alcoholic hepatic disease or alcoholic hepatitis. So what happens that when there is excess consumption of alcohol, what happens that this alcohol is carried to the liver, and in the liver it is acted upon by the enzyme alcohol dehydrogenase and is converted into acetaldehyde. During the conversion of alcohol into acetaldehyde, the NAD plus is converted into NADH, and this conversion of NAD plus to NADH results in the formation of reactive oxygen species. Normally, the NAD plus, it accelerates fatty acid oxidation and decrease the chances of fat accumulation in the liver, while the NADH, it facilitates the fatty acid synthesis in the liver. Now, what happens that if more NAD plus is converted into NADH, what happens that there is less NAD plus to facilitate fatty acid oxidation, and as a result there is decreased or less fatty acid oxidation. While on the other hand, the formation of NADH from NAD plus, which increase fatty acid synthesis, so more formation of NADH will facilitate more fatty acid synthesis. Less fatty acid oxidation and more fatty acid synthesis will result in the excess fat accumulation, as these fatty acids will combine with the glycerol, alpha glycerol phosphate to form triglycerides, and these triglycerides are accumulated in the liver. The process is known as the steatosis. Since this process is the cause behind is the alcohol, so we say that as alcohol-induced fatty liver disease. Now, what happens here that when the alcohol is converted into acetaldehyde under the action of the alcohol dehydrogenase, and during this process NAD plus is converted in NADH, so reactive oxygen species are generated, and we know that how reactive oxygen species are dangerous for the cells, because these reactive oxygen species cause lipid peroxidation of the membranes, oxidative modification of the nucleus and nuclear proteins, and uh, damage to various cytoplasmic and nuclear proteins. Moreover, this acetaldehyde has the ability to combine with various cellular components like cell membranes, nucleus, and cytoplasmic components. And when the acetaldehyde combined to these cellular components, it results in the formation of acetaldehyde adducts. And by acetaldehyde adducts, we mean that components, they are made non-effective or non-functional. Now, since these acetaldehyde adducts are non-self for the immune cells, so what happens here, that these acetaldehyde adducts are recognized by the immune system, and here a component of inflammation is added to the steatosis, which is abnormal fat accumulation in the liver. And this inflammation results in the formation of neutrophilic infiltration, and this infiltration or in this neutrophilic infiltration and inflammation further damages the hepatocytes and results in the chronic inflammation will results in the in periventricular fibrosis. And if the process continues, and if the alcohol consumption continues, ultimately the steatohepatitis will result due to the addition of the element of inflammation, and after the steatohepatitis there will be periventricular fibrosis, and ultimately it will lead to cirrhosis and liver failure. Now, there are some other causes other than alcohol that can cause fatty liver, and commonly these causes include diabetes, in which insulin resistant occur. Obesity is also characterized by the insulin resistance, and there is a condition known as the metabolic syndrome, in which there is hypertension, diabetes, hyperlipidemia, hypertriglyceridemia, and all these conditions are characterized by the insulin resistance that we commonly see in type 2 diabetes. We know that insulin normally inhibits lipolysis, and normally it causes deposition of fat and stimulate the triglyceride synthesis. But when the insulin receptors become resistant, and if they are not working properly, this situation will accelerate lipolysis and breakdown of triglycerides into free fatty acids. Now, these free fatty acids are carried into the mainly from the adipose tissue into the liver, and the increased entry and synthesis of free fatty acids in the liver will lead to accumulation of abnormal excess amounts of fats in the liver, and it will cause non-alcoholic fatty liver. The fatty acids we now are converted into triglycerides in the liver when they combine with the alpha glycerophosphate, and the triglycerides are formed, and normally these triglycerides are carried from the liver through the lipoproteins, particularly in the VLDL lipoproteins. But if there is any problem somewhere, and if there is decreased removal of these triglycerides and fats from the liver in the lipoproteins, they will get accumulated in the liver and will result in the fatty liver known as the non-alcoholic fatty liver, because here the cause is not alcohol. Now, what happens that in a normal liver, when there is excess fat accumulation, the liver is enlarged, its size is enlarged, it becomes soft due to excess amount of fats, its color becomes yellow due to the presence of fats, and it becomes greasy or oily in gross appearance. Now, here we can see various causes that cause fatty liver. For example, in obesity, diabetes, alcohol, increased consumption of alcohol, what happens that there is excess entry of lipids into the liver, In alcohol consumption also there is increased esterification of fatty acids into triglycerides when the fatty acids combine with alpha glycerophosphate to form triglycerides. And in diabetes mellitus, there is accelerated lipolysis and increased breakdown of triglycerides into fatty acids results in the increased entry of fatty acids and also the enhanced fatty acid synthesis by the hepatocytes. There is decreased oxidation of the fatty acids, and this condition may also occur in hypoxia. Alcohol may do the same, and sometimes the liver toxins like carbon tetrachloride may lead to decreased oxidation of fatty acids in the mitochondria of the hepatocytes, and it will lead to the accumulation of fat. If the lipoproteins is impaired, if this will impair the pathway by which the lipids are carried out from the liver. So alcohol also induced impaired lipoprotein excretion, and normally the fatty acids that are carried out from the liver in the form of VLDL, the triglycerides are retained in the liver leading to fatty change. So here we come to a summary that these fat droplets may be in the form of micro droplets are in the form of macromolecules when the micromolecules unite to form large fat globules, microglobules, and these are the macroglobules. So in mild form, this fat accumulation has got no effect. But in severe form, what happens that the accumulation of these fat globules in the cell will fill the cytoplasm of the cell. It will push the nucleus towards the edge of the cell, and if a component of inflammation is added, then the steatosis is converted into steatohepatitis, and it may be in the form of alcoholic steatohepatitis or non-alcoholic steatohepatitis. We know that obesity and diabetes, in this condition what happens that there is insulin resistance. The cellular receptors for insulins, they become defective, and as a result, when there is no insulin, there will be accelerated lipolysis and lipid breakdown, and this will lead to increased fatty acid synthesis, increased entry of fatty acids into the liver, and decreased removal of the fats. And in the same situation may happen in starvation, where there is increased fatty acid mobilization. The toxins like carbon tetrachloride and the protein malnutrition, when there is a deficiency of the protein, this will lead to decreased apoprotein synthesis, and when there is decreased apoprotein synthesis, there will be decreased formation of the lipoproteins and decreased passage of the lipids from the liver into the circulation. The anoxia or hypoxia and excessive alcohol consumption also inhibits fatty acid oxidation, and when the fatty acids oxidation is interrupted, when the fatty acids are not oxidized for energy, automatically they will get converted into triglycerides and will get accumulated in the hepatocytes and will result in the formation of fatty liver. So initially, when fats get accumulated in the liver, the liver is converted into a large, greasy, yellow, soft, enlarged organ. But if the process continues and if there is more and more fat accumulation in the liver, it will lead to steatosis, and sometimes during steatosis there is fatty acid oxidation, and that will lead to an oxidative stress. At the same time, the antioxidant mechanisms are suppressed, and the excessive oxidative stress due to fatty acid oxidation and decreased antioxidant mechanisms will lead an element of inflammation, and steatosis is now converted into steatohepatitis. Now, a liver with steatohepatitis in the long run, it will lead to perivenular fibrosis, and ultimately it will lead to cirrhosis and finally liver failure. Under the microscope, when we treat the tissue during the tissue processing mechanism, we treat the tissue with xylol, and the xylol will dissolve fats in the cells. And finally, under the microscope, we will see empty spaces, empty cells, and all these empty cells, they represent the fat laden hepatocytes. So under the microscope, we will see the fat cells, and these empty fat cells, these empty spaces represent the accumulation of fats in these cells. Thank you very much.